Good evening and welcome to the New York State Vaccine Equity Fireside Chat. My name is Louise Square and I am the Health Equity Coordinator for the New York State AIDS Institute. I will be your moderator for the evening. Just a quick overview of what the hour will look like. You've already been welcomed by me. Next, we'll have some housekeeping tips. And this week's chat will be slightly different from the others we've brought you. Today, we will have a presentation from Dr. Randall Heyer, the Senior Vice President for Global Medical Affairs at Moderna. Afterwards, we have our other panelists who will join us and Dr. Heyer to answer your questions that have been sent in by you, our audience members. Next slide, please. So housekeeping. To ask a question, thank you to those that have submitted in advance. We will address as many questions as we can within the time constraints of the program. But to submit a question during the program, please email COVID-19 vaccine equity at health.ny.gov. Next slide, please. So without further ado, I'm going to turn it over to Dr. Heyer. Dr. Heyer, you're unmuted.
Yeah, I'm with you now. Here we go. I'm unmuted. Can you see my slides now?
Not just yet.
Okay, let me just check. 1 second, please. Sorry. Share screen. Here we go. Okay, there we go. How is that? Can you see them now?
Yes.
Great.
Yes.
Super. Good evening, everybody. I'm Dr. Randy Heyer from Moderna, and tonight I'd like to take this opportunity to share with you a little bit about the Moderna COVID-19 vaccine. And I just want to thank the organizers so much for this opportunity to share this moment with you. It means a lot to me. To start, I need to tell you a little bit about the Moderna vaccine. It's available under Emergency Use Authorization, or EUA, and it has not been approved nor licensed by the Food and Drug Administration, the FDA, but it has been authorized for emergency use by FDA under emergency use authorization to prevent COVID-19 in people age 18 years and older. There is no approved, FDA-approved vaccine to prevent COVID-19. This emergency use is in effect for the duration of the declaration justifying emergency use of the product, unless that declaration is terminated or the authorization is revoked sooner. And for more information on the authorized use of the Moderna COVID-19 vaccine and mandatory requirements of the emergency use authorization, there's a fact sheet available at the website shown here on the screen. Let's get my slides to work here. Great. Hold on. Okay. Good. So I need to go a little more detail. As I mentioned, it's authorized for use under emergency use authorization to prevent coronavirus disease 2019, known as COVID-19, that's caused by the severe acute respiratory syndrome coronavirus number 2, known as SARS-CoV-2, in individuals 18 years and older. The Moderna COVID-19 vaccine is investigational and not approved by FDA. There's some important safety information I need to cover. The vaccine, you should be not administered to individuals with a known history of severe allergic reactions, such as anaphylaxis, to any component of the Moderna COVID-19 vaccine. And again, for more information about this is available at the URL shown here at the bottom of the slide. The acute allergic reactions need to be appropriately managed, and medical treatment should be available to manage them immediately in the event of an acute anaphylactic reaction that would occur following the administration of the COVID-19 vaccine. And their CDC publishes very good guidelines for management of this at the website shown here. I should mention that people who are immunocompromised, including individuals who are receiving immunosuppressive therapy, may have a diminished response to the Moderna COVID-19 vaccine. And the Moderna COVID-19 vaccine may not protect all vaccine recipients. In our clinical trial, following the administration of the vaccine, we noted that people had adverse reactions that included pain at the injection site, fatigue, headache, myalgia, arthralgia, chills, nausea, vomiting, axillary swelling or tenderness, fever, swelling at the injection site, and erythema at the injection site. There were additional adverse reactions, some of which may be serious, may become apparent with more widespread use of the Moderna COVID-19 vaccine. And again, for the full details, full prescribing information for providers and fact sheet is available at the URL shown here below at the bottom of the slide. I need to mention that the vaccine provider has certain mandatory reporting requirements of the following events to the Vaccine Adverse Event Reporting System, known as VAERS. That includes vaccine administration errors, whether we're associated with the adverse event, whether or not associated with an adverse event, serious adverse events, irrespective of attribution to vaccine, cases of multi-system inflammatory syndrome in adults, and cases of COVID-19 that result in hospitalization or death. And people should submit the reports to VAERS online at the website shown here. For further assistance, there's a telephone number and description on words to put in the description section of the report. You should also report that to us at the phone number shown here on the slide, or provide a copy of the VAERS report with the fax number here or the email address. And again, for more information is available at the URL shown in the bottom of the slide. And finally, regarding pregnancy and lactation, the available data on the Moderna COVID-19 vaccine administered to pregnant women are insufficient to inform vaccine-associated risks in pregnancy. Data are not available to assess the effects of the COVID-19 vaccine on the breastfed infant or in milk production or excretion. The vaccine is administered intramuscularly as a series of 2 doses, 0.15 milliliters, or 0.5 milliliters, 1 month apart. And there are no data available on the interchangeability of the Moderna COVID-19 vaccine with other COVID-19 vaccines to complete the series. Therefore, individuals who have received 1 dose of the Moderna COVID-19 vaccine should receive a 2nd dose of the Moderna COVID-19 vaccine to complete the series. And again, for more information and details, please see the website shown here below at the bottom of the slide. Thank you. Let me talk a little bit now about the vaccine itself. I think there were some interesting questions in this. And honestly, what it is, it uses this new technology or platform called messenger RNA. And in here is obviously a schematic of the messenger RNA that's encapsulated in a lipid particle, a lipid nanoparticle, because it's so small, known as LNP. And it turns out that we've been studying coronaviruses for some time, so we know what to target in our vaccine, and that's this protein called the spike protein, shown here in blue in a much bigger picture over here. And so the mRNA encapsulated in the lipid nanoparticle after injection into the muscle is taken up by the cells in the draining lymph nodes of the injection site. The mRNA is translated into protein on the ribosomes, the standard cell machinery, to produce a natural version, as natural as can be, of the SARS-CoV-2 spike protein that go to the cell surface here, that then are available for the immune system to recognize and to develop an immune response. So we take that known DNA sequence, in this case, it's the sequence that produces the spike protein of the virus, and that's the template to develop the messenger RNA from it. This is combined, of course, of enzymes, buffers, nucleotides to produce the mRNA, which is then encapsulated with lipids in this lipid nanoparticle, which then goes on to become the vaccine product. And then the story here, I think, is just a story that needs to be told, which is how rapidly we were able to develop this vaccine and make it available for use. The sequence of the SARS-CoV-2 was identified on the 11th of January 2020, the sequence shown here. And then it was on the 18th of December that the FDA made the vaccine available for emergency use, which is just a remarkable feat and will be a story that will be told many times to come. And the question is, how did that happen? How were we able to do that? And there were really three major enablers. One was the science, that we've been studying these types of viruses for many years now. So the SARS-CoV-2 is just one of many coronaviruses we've been studying. Actually, I was on the ground at the World Health Organization in 2003 when the first SARS outbreak occurred. So we understood a lot about it, and particularly what sequence to look at. There was also, of course, a large unmet need and shared sense of urgency. And I don't think I have to explain that to anybody. And there was a very close collaboration with stakeholders, including the government, contract research organizations, and close cooperation and clarity from the regulators about what was needed to be done to make a vaccine available. And so it was, I think, quite remarkable. If you think about it, when the virus sequence was identified and the virus was identified, there were basically no cases in the United States. And 180,000 later, we had a vaccine available. And of course, now we know, the case number in the United States is considerably higher. This is what the development plan looked like. And it started, way back in February of 2020. And of course, as I mentioned, the vaccine was made available for emergency use in December. And what's important is the vaccine has gone through what's effectively a full development program, including 3 phases, phase 1, phase 2, and phase 3, plus additional studies that we're going to do in other populations for further evaluation. And what was helpful here, and why this was able to be an accelerated development program, is we really understood the science behind the vaccine. The very technology, mRNA technology, allows us to start quickly and scale quickly. The close collaboration I spoke about, plus the large number of cases that occurred late in 2020 allowed us to complete the trial very quickly, try to determine whether the vaccine worked or not. I want to speak briefly now about the phase 3 study. This was the study called the COVE study that brought the study to emergency use authorization. And I think what's very important about the COVE study is that it really did represent the US population at risk for COVID-19 disease. And this was a determined effort by Moderna and our partners to recruit a population for the study that best represented the United States, and particularly those at risk for COVID-19 disease. And as you can see here at the faces, plus the boxes here, you can get an idea of who actually was in the 30,000 person study. So we had nearly 6,000 participants who identified themselves as Hispanic, 25% over 65, a roughly equal proportion of men and women, about 22% of healthcare workers, 40% aged 45 to 64, nearly 8,000 people living with chronic disease that we know many of those can make us more susceptible to COVID-19. We had many retail, restaurant, hospitality workers, 2,000 participants. 29% were younger folks, about 3,000 African Americans, and nearly 10% were educators and students. This was very important because it was really key to make sure that the study represented the people who were suffering, who were most affected by COVID-19, so we could show that the vaccine could work in these populations. And here's those demographics I showed you in the picture, now just shown on a slide here. And as you can see, if you look at the proportion of various racial or ethnic groups, and look at the US population proportion over here in the right column, and then look at the proportion of those individuals in the COVE study, you can see that there was actually pretty close representation of the US population in the COVE study itself, which again is very important for the study and to provide the information that we need. Here's the age and and sex profile. Older individuals were also well represented in the study, nearly 25% age 65 or older, 40% age 45 to 64. Females were represented roughly equal to males, 47% female and 53% male. And this was important, as I mentioned, we felt that the COVE study was able to enroll a diverse population that mimicked the characteristics of the general population. This slide's a little more data on it, but I'll walk you through it carefully. And so really what we're trying to show here is that the medical comorbidities, diseases that we know make people more susceptible to COVID-19 disease, were represented in the COVE study. The most frequent one, of course, was diabetes, here at 9% of the population. And the way this works is the two columns here on the left represent the people who were in the vaccine group, and the two columns here over on the right represent the people in the placebo group. And as you can see, the numbers were roughly equal because these were randomized populations. We also had people with severe obesity, people with chronic lung disease, significant cardiac disease, liver disease, and HIV. And this was the study design. It was actually a very simple study design. We took just over 30,000 participants, randomized 1-to-1 to receive either the investigational Moderna COVID-19 vaccine known as mRNA-1273, that's our name for it, 100 microgram injections, 2 of them, or they got saline placebo, 2 injections. And of course, we didn't know who got what until we had enough cases to accumulate, and then we examined who got vaccine, who got placebo, and were able to figure out the effect of the vaccine. Now, what's important, of course, is how do you define your case? And so we defined the case. It's actually very simple. To be a case in this study of symptomatic COVID-19, you had to first have a test. The test had to say that you had the virus infection via a nucleic acid test. So you had to have the viral RNA in you. And you had to have either 2 systemic symptoms, fever, chills, myalgia, headache, sore throat, and so on, or 1 respiratory syndrome, cough, shortness of breath, difficulty breathing, clinical radiographic evidence of pneumonia. That defined as a case. And we started counting them at 14 days after the second dose. Now, this is, again, I'll walk us carefully through these data-rich slides. This is the primary efficacy. So this was the point when we accumulated enough cases. In this case, it was 196 total cases. We then looked to see who got vaccine and who got placebo. And it just happened at our primary endpoint, 11 individuals in the vaccine group got symptomatic COVID-19 and 185 in the placebo group. So clearly a distortion from even distribution, and that showed that the vaccine efficacy was 94.1%. That was considered to be very statistically significant. This slide is very busy, but it's very important, and I'll tell you why. And just bear with me, please. If we look at vaccine efficacy, this third column here, the blue dots here represent the point estimate for efficacy, and here's the number. So as the number I just told you, 94.1% is shown here as this blue dot in the overall population. If we look at then people who have risk for COVID-19, either by age or because they have comorbidities, or because they are older and have comorbidities, you can see that though the efficacy went down slightly, it was still very high. And what I find particularly reassuring is to look at the older folks, those 75 years of age and older, with or without comorbidities, clearly at risk for COVID-19. The case splits were 0 in the vaccine group and 7 in the placebo for very high efficacy. Then it was similar between men and women. And then if we just asked anybody who had a comorbidity, it was slightly lower than if you didn't, 90% versus 95. What I think is really interesting is we look at the race and ethnicity groups, and we just made a simple comparison of people who were either non-Hispanic white, showing efficacy of 93.2%, or those who weren't, or communities of color. We had one in the vaccine group and 41 in placebo, with a very high point estimate of efficacy of 97.5%. So this was obviously very reassuring. Then if we went to a different endpoint looking for severe COVID-19, so this is people who had symptomatic COVID-19, but in addition had symptoms that was consistent with severe disease. We looked at that, and there were 0 in the vaccine group and 30 in the placebo group, representing a point estimate efficacy of 100%. This graph shows the accumulation of cases in either the vaccine group or the placebo group over time. And the time is time from when they entered the study or were randomized. And as you can see, here's the first dose of the vaccine, and then the second dose of the vaccine or placebo, because this is the randomized, at 28 days later. And as you can see, those who received placebo accumulated cases, much faster and much more cases than those who received the vaccine. And as you can see, the curves begin to split roughly around day 12 or so. This, using a slightly different definition of efficacy, shows an efficacy of 93%. So very high vaccine efficacy. And you can see the difference in the curves between the placebo group and the vaccine group. Then looking at a analysis for asymptomatic disease. So this is for people who had, or asymptomatic COVID. That is, they had a positive test for nucleic acid, that is, they had viral RNA, but no documented COVID-19 symptoms between the first and second dose. You can see that in the vaccine group, there were 14 people, and the placebo group was 38 people. Now, it's clearly lower in the vaccine group. It's not definitive, and we can't really say that it has an effect. It certainly suggests there may be an efficacy for prevention of asymptomatic disease, but it's not conclusive. Now let's turn to safety, because safety is very important. We look at, and I'll help you with this graph, so just bear with me, please. This is what we'll call solicited local adverse events, reactions, And we define these as pain, erythema, redness, swelling, or axillary swelling or tenderness. And we measure them on grades in this scale. We show grade 1, 2, and 3. And what you can see in the vaccine group, which is the upper row, compared to the placebo group, which is the lower row, after the first injection, clearly a large number of vaccine recipients reported pain. And you can see that there were smaller reports of erythema, swelling, or axillary swelling or tenderness. And down here, you can see that in the placebo group, people also reported symptoms, local adverse reactions, though clearly at much lower percentages. After the second injection, we saw, a high number of reports of pain in the vaccine group, very similar reports of placebo, and with a little bit more erythema, a little more swelling, a little more axillary swelling or tenderness in the vaccine group. So what we saw is that the local adverse reactions, there were more of them after the second dose versus the first dose. Now, if we go to systemic adverse reactions, which we defined as fatigue, headache, myalgia, muscle aches, arthralgia, chills, nausea, or vomiting, or fever, you can see that whether you were in the placebo group was sort of similar to reactions, whether it was fatigue, headache, myalgia, arthralgia, chills, nausea, fever. Most of these did resolve within 1 or 2 days. And this is important, is that if you were administering the vaccine, you certainly want to warn people that this effect may occur. Then if we look at adverse events that beyond the ones that occurred within the first 7 days, we can look at this graph here, this table here shows the vaccine in the left column and the placebo in the right column. And we look at any adverse events, you can see the percentages were very similar between the vaccine group and the placebo group. Any medically attended adverse event, that's an adverse event somebody experienced where they sought medical care. You can see the percentages were very similar between the vaccine and placebo group. Same with any serious adverse event, which is, usually involves hospitalization or more serious. It was very low, 1% on either group, as well as any death that was reported in the study, very similar between the vaccine and the placebo group. We do know that anaphylaxis has been reported with the administration of the Moderna COVID-19 vaccine, and it's been published in the Center for Disease Control's MMWR, and we know that first course anaphylaxis is a serious life-threatening allergic event that occurs rarely after vaccination, and the CDC did do a very close assessment of that and showed a rate of 2.5 million cases of anaphylaxis per 1 million doses administered. And of the 10 cases they identified, 9 of them showed onset within 15 minutes of vaccination, and no anaphylaxis-related deaths were reported. And why that's important is that per CDC guidance for administering these vaccines, vaccinators should adhere to that guidance, including screening recipients for contraindications precautions, having the appropriate supplies and staff available to manage anaphylaxis, and implementing those recommended post-vaccination observation periods. And of course, having epinephrine available for treating suspected anaphylaxis. I want to talk about just briefly about the vaccine shipping, storage, administration. The vaccine is shipped at minus 20 degrees C. That's a standard freezer. We can ship as small as a single carton or 100 doses. Once on site, the vaccine can be stored, of course, up to the date of expiry in the freezer as it was shipped, or in the refrigerator at 2 to 8 degrees C, normal fridge temp, up to 30 days, or at room temp for up to 12 hours. And there's also local transportation under controlled conditions at refrigerator temperature. When the vaccine is administered, it comes out of a multiple dose vial. The vaccine should be administered within 6 hours after the first entry into the vial, and there's no dilution. We use standard needles and syringes available at health clinics. So with that, I'd like to end my presentation, and I look forward to answering your questions along with my fellow panelists. Thank you.
Thank you, Dr. Heyer.
Did I stop?
And so we're going to bring our slides back up, and I'm going to move on. I just want to thank you. I'm honored and privileged for this opportunity to have a discussion with our presenter and our panelists. So all of our guests have extensive and impressive bios that have been condensed a little bit for the sake of time so that we can get to all of your questions. So our first panelist that I'm going to introduce is Takesha Leonard, family nurse practitioner. For the past 11 years, Ms. Leonard has worked as a family nurse practitioner and medical director for Eastside Jericho Road Community Health Center. Under her direction, the Jericho Road team created the first no-barrier COVID-19 testing facility in Buffalo, New York. To date, her team have tested over 20,000 community members throughout the city of Buffalo. Her primary interests include educating secular organizations, schools, and faith-based organizations on social determinants of health as it relates to health disparities, particularly in marginalized communities. As a member of the New York State COVID-19 Vaccine Equity Task Force, Takesha has been working daily to promote education regarding the COVID-19 vaccine and primary prevention of COVID-19 virus. Next, we have Dr. Jennifer Davila. Dr. Davila is a board-certified pediatric hematologist oncologist and an attending physician at Children's Hospital at Montefiore. Her primary academic research interests include quality improvement efforts to improve thrombosis risk assessment in pediatric populations. specifically explaining the clotting risk in patients with sickle cell disease. Dr. Davila's work has been published in various manuscripts, reviews, book chapters, and abstracts. She has been invited regionally and internationally to speak on the depths of her work. Dr. Davila works now include investigating the effects of COVID-19 in special populations that have been hospitalized with severe hematological responses. You've already met Dr. Heyer, but I'll read you a little more about him. Dr. Randall Heyer, as has been previously stated, is a senior vice president for global medical affairs at Moderna. He has over 3 decades of experience in medicine and public health in both private and public sectors. After completing his formal education and spending time in Antarctica as a station physician, Dr. Heyer shifted his primary focus to public health and vaccine initiatives. Dr. Heyer served 4 years at the World Health Organization and as a medical officer responding to outbreaks and emergencies including anthrax, Ebola, SARS, and the avian influenza, to name a few. Dr. Heyer's experiences cover many areas, but his work on vaccine development is most impressive. He was pivotal to the 2017 approval of a 2-dose adult hepatitis B vaccine that is currently in use today. Beyond development, his responsibilities have included directing vaccine and pharmaceutical safety programs, overseeing vaccine clinical operations, engaging medical students and policymakers, and managing crises. Dr. Heyer co-authored a popular World Health Organization handbook on risk and crisis communication during public health emergencies. I want to thank you all for being here, and I look forward to our discussion. I'm also happy to tell you that we got a ton of questions from the community, and we're so grateful for their interest in this discussion. We'll try to get to as many as possible. So for our panelists, I'll ask you to please be concise, but as thorough as possible. So our first question, and Dr. Heyer went over this a bit in his presentation, there were many concerns from the public regarding the speed with which the vaccine was developed and also approved for emergency use. In the graphs, we saw that they went over several categories, but we didn't delve into the safety and the safety of the vaccine. So how can all people, particularly communities of color, trust that the appropriate steps were taken to ensure that this vaccine is safe and effective?
Sure. Well, I'll start with that, Louise. Certainly it's up to the Food and Drug Administration to make that determination. We make the data available to them, and they determine that the vaccine safety and efficacy supported authorization for emergency use, given what's going on with COVID-19. Let me talk about that a little bit, about the speed of development. The science, as I mentioned earlier, the science underpinning the vaccine was known, okay? We knew what the protein was to go after. And, if you look, all vaccines that are being developed right now, we're all targeting the same protein. It's the spike protein, the virus. The second thing about the speed is that as I mentioned earlier, the mRNA technology allows us to start quickly and move and scale quickly. That's an advantage that's with this platform, inherent to the platform. And again, the close collaboration with the government, academic, community partners, and so on. The vaccine certainly met the FDA standards for safety and efficacy. And I think the thing to remember, and I think I talked about this a little bit, is that when you develop a vaccine, you have to have enough cases to occur in the population you're studying to see if the vaccine has an effect. Well, sadly, as we all know, there was a large number of COVID-19 cases last year in the United States, particularly in the late fall. And that allowed us to accelerate the time frame for development of the vaccine simply because we had so many cases and were able to make a determination on the efficacy of the vaccine. I'd like to emphasize that the phase 3 study is not over. It's still ongoing. We're monitoring the study for safety and effectiveness. The CDC and other government regulators and private institutions are monitoring the safety of the vaccine in the population, of course. So that's the most thorough answer I can give.
Thank you, Dr. Heyer. I'm going to just be a little bit of a nudge if you can keep your answers as concise as possible, because we have a lot of folks that are interested in this. And Dr. Davila, I just wanted to give you an opportunity to speak to this a little bit also, because the emphasis was really, and the question was really on trust from communities of color. How can they trust that it's effective? So would you like to speak to that?
Sure. So I think, taking it back a step, and as an oncologist, a pediatric oncologist, I think one of the things that I've been telling my patients and my patients' parents, because I do treat pediatric patients, is that the mRNA platform is not new, right? And this is something that Dr. Heyer has already alluded to. It has been used in human trials of cancer vaccines for over a decade. So if, theoretically, if there really was a problem with the vaccine, right? At this point, we would have known, not the vaccine, but with that platform, we would have known that by now. So I think that as physicians, as scientists, we feel that this is a safe platform to use to develop a vaccine. And that's something that I really want to emphasize to the population, is that this is not like, COVID happened and all of a sudden we're like, okay, let's use mRNA. It's been there for a very long time. Science has been there. It's not new.
Thank you, Dr. Davila. I think that's really important. I don't know how many people know that the platform has been used for a long time, especially around cancer. So I'm going to turn next, and I want to make sure that next we allow Takesha Leonard to answer next, but I'm going to turn to Megan for our next question.
Thanks, Louise. We had a lot of questions where people were asking about how soon after they receive their second dose they can get back to normal life. William and Joe wanted to know when it would be safe for them to socialize with small groups, or what precautions should they continue to take after they get their second dose to help protect themselves and their families.
Takesha, do you want to take that first?
Sure. So the studies are showing that 2 weeks after your second dose, that you are considered in that 95 to 97% vaccinated. But that still leaves a little wiggle room for infection, some sort of breakthrough COVID infection. So that's why we still say we want you to wear your mask, practice your social distancing. That's why we're saying that we're not completely just letting go of the reins, but you can feel more comfortable that you are vaccinated in order to have your small group settings, but still practice precautions. And the other reason for that is that, everyone around you is also not vaccinated. So we actually want to be an example that even though we got vaccinated, we still want to encourage those that have not gotten vaccinated to do all the proper things to prevent the spread. So about 2 weeks after your second dose.
Thank you so much. Does anyone else want to address that question before we move on?
Yeah, I'll add just a little bit. I think what Takesha said makes a lot. It definitely is the right way to go. I mean, we know that the vaccines can help people from getting sick, but we don't know what the vaccines can do about transmission. And I think until transmission comes down considerably and the burden of disease in the population, we need to maintain our social distancing, wash our hands, keep our distance, wear our masks to help prevent people from getting COVID-19. Thank
you so much. So our next question, and you alluded to this in your slides, Dr. Heyer. There were about, if I remember the slide correctly, there were about 3,000 people of color, Black people that took part in the trial, and there were about 6,000 Latino, Latinx folks that took place. But in looking at the further slide, and maybe you can explain this a little bit better, and all of you can answer if you like, but it looked like you said there was one who had who got the vaccine, and then there were like 41 placebo. Yep. So I hope I'm remembering, because there were a lot of slides. But but basically the question is, why were there so few Black and brown participants in the trial? And then what efforts did you make to recruit more people of color? But we do see that people of color were in it, but I just wanted to ask that question. Sure, it's a really important question. And I think it gets to the question that I was attempting to answer earlier is, how do we know about the safety in folks of color? The thing is, Moderna made a very big effort to enroll ethnic and racial minorities in this study. And the result of that effort was roughly, some 37% of the people in the COVID study are people of color.
your memory, your visual memory is excellent. You recited the slide perfectly. If you study the population of people of color who did get symptomatic COVID-19, there was 1 person in the vaccine group and 40 in the placebo group, representing obviously very high vaccine efficacy. And then maybe, does that address your question, or would you like me to go?
Yes, I think so. I think it does.
Okay.
So unless someone else wants to address that, okay, I'll move on to the next question. And I think Takesha and Dr. Davila, you can answer this if you like. Well, all of you can answer it. Many people of color believe that the COVID vaccine can give them actual COVID vaccine virus. So can you talk about why that's not true? Dr. Davila, can we start with you?
Sure. I think if we look back at the slides that Dr. Heyer has shown us, right, the goal of the vaccine is to sort of, trick the body into making the viral protein itself and then causing our immune system to respond to it. So it's not that we're actually getting the virus, making the virus and infecting ourselves. We're just sort of showing our immune system, look, this is what it looks like. So if you ever see this again, just make sure you respond to it, right? And it's not giving us the machinery to produce this virus. It's just letting us kind of show it on the surface of our cells. So it's theoretically, we're not introducing this virus to ourselves. We're not making it ourselves, if that makes any sense.
Yes, thank you so much for that. Takesha, did you want to address that?
Oh, I think that's good. I describe it as like our bodies, producing the antibody. So the next time we're introduced to the virus, we have that radar that says just kill this on site. And so we're not actually getting the virus, but we're just making the proteins to protect us against, us being infected. So.
Thank you so much. I think Megan has another question for us.
Yep, we do. Barbara and Stan both submitted a question. They had read some conflicting information about the safety of taking over-the-counter products like Tylenol, Advil, or Aleve shortly before or after being vaccinated. They were wondering if people can take those medications around their vaccines, and if there are any other medications that they should ask their doctors about being impacted by the vaccine.
So you want to try that one, Dr. Davila?
So I was actually going to let Takesha take that one because I think she's probably had way more people that have you've given the vaccine to.
So what I would say is that I personally have not heard of that. So just as an aside, and I'll keep this brief, after my second dose, I probably experienced every symptom in Dr. Heiler's slide. I had the body aches, I had the chills, and I don't call into work, y'all. I go to work every day. I called in that day. I laid in that bed. I drank a lot of water and I took Tylenol. It lasted a full 24 hours. The next day, I was 100% back to normal. And so I think that the most important thing is check with your doctor just to make sure there are no contraindications to the medications. I don't know all the medications, in the world, but what I know is that I personally took Tylenol. A lot of the people that I know, I got the vaccine for the body aches and things like that, took Tylenol. But what I will tell you guys is that I woke up the next day and I was totally fine. And, here I am. So.
Yeah.
I think the concern with taking the Tylenol versus ibuprofen, right, is that ibuprofen, Aleve, any of these medications are considered anti-inflammatory medications, and I think that if you think about it theoretically, your body, the way that it responds to the vaccine is by causing an inflammatory response. So if you're taking a medication that can somehow mute that response, I can see why theoretically people may say, oh, don't take those medications, right? And I will defer to Dr. Heyer, but I don't think that there's any data that shows that that's actually happening, right? So I think that Takesha, I was in bed chilling 24 hours, and I was actually happy because I'm like, oh my God, it's working.
That's right.
And I took Motrin and I took Tylenol because I have 2 small children and I needed to be on point, but the same thing, I was fine. So
thank you. Dr. Heyer, Dr. Davila deferred to you.
I made 2 outstanding answers. I can't top those.
Okay.
So.
Okay, no problem. So I have one last question, one more question. Um, and that is, we're gonna shift gears just a little bit. So what is the current age range for vaccine eligibility, and when will children have the ability to be vaccinated?
Yeah, well, our vaccine is available, as I mentioned in the slides, for adults age 18 years and older. As I mentioned in the slides, we are studying the vaccine in younger populations to provide safety and efficacy data that may inform the FDA to expand that. But we have to conduct those studies first, produce the data, and the data has to be reviewed, of course. So right now, that's as much as I can say.
Okay, thank you. Thank you for that. So this is for everyone. Can we get COVID-19 after our first dose? Everybody's smiling. Okay.
Well, I'll answer it first if you want. Of course you can. We don't know. I mean, that's the answer I would have to say. Just out of the 96% of people in the study got the second dose. So that means I have very, very little data to talk about what happens after just one dose.
Thank you.
Yeah. I mean,
does anyone else? I'm sorry, Dr. Heyer, go ahead.
It is a 2-dose vaccine. That's what people should get, 2 doses.
And that's why I agree with Dr. Heyer, get your second dose, because that's where the studies show that you have the best chance of getting the full, effectiveness of the vaccine. There's not enough studies out there to, I don't think we could expose people to COVID after first dose to see if they got it or anything like that, but get your second dose. And while you're waiting, make sure you're doing all the proper things to keep yourself and your family and your communities protected. So that's what I would say.
Right. The hand washing, the social distancing. Right.
That's right.
Yeah. Dr. Davila, you wanted to say something?
And I think the important thing, when patients ask me this, what I say, and when I try to assimilate it to, is a little bit like the flu, right? We all get the flu shot, and, people still get the flu. They'll still develop the flu or catch the flu, right? But you find that when you've had the flu vaccine, your symptoms are just not as bad. You may not develop a pneumonia. You may have some fever, but otherwise you're back to normal, to functioning level by 48 hours, 72 hours. Whereas somebody who may not have gotten the vaccine will be sicker, right? And I think, if anything, it's just kind of almost a little bit of an insurance that, okay, if I do get it, I may not get as sick, right? And we don't know with 100% certainty, but, we've seen it in other viruses. So you can just hope for the same thing.
Thank you so much. And Megan has another question for us.
Yeah, thanks, Louise. We received a lot of questions about the potential need for a booster shot, either in response to some of the variant strains or as a continuing preventive shot moving forward. So Diane and Lisa were wondering, is this something we're going to need booster shots for in the future, like flu shots, or is there going to be another shot coming out in response to variant strains?
I mean, I can start it out. So the honest truth is, I don't know. That's the honest truth. I don't know. Time will tell. We're certainly aware of the variants. Along with everybody else, we're working very closely with the government and others to monitor variants. And we've been proactive. We are developing plans to modify the vaccine if needed, or booster plans or whatever. But those are plans right now that we're putting together. We don't have data, and I don't think anybody could honestly answer your question right now.
So just to add to Dr. Heyer, what I would say is that's why it's so important that when your time comes to get vaccinated, that's why it's so important, because the more of us that get vaccinated, the better chance we have of stopping that this virus is changing. And so, when your chance comes and your time is up, the best chance we have to beat this thing, guys, is to get ourselves vaccinated, as many of us as we can. So
thank you for that. So Megan has another question for us.
Yep, Louise. We actually had a question. We had a lot of people ask us questions about how the vaccine may affect people with various existing health conditions. Deb wanted to know if side effects would be greater for somebody that has an autoimmune disease. Stacy asked about diabetes. So in general, are there things that people should be talking to their doctor about before deciding to get vaccinated? And how can they find more information about how their existing health conditions might impact their vaccination?
Yeah, Dr. Davila, would you like to address that, especially because of what you do and the people you treat having cancer? Would you want to take that one first?
So I think that, again, I treat pediatrics. So we haven't, unfortunately, we're not able to offer the vaccine to children as of yet. But I think that children or people that have any kind of chronic disease or something that affects their immune system is probably the primary population that you want to protect, because, immune or chronic inflammatory diseases affect all parts of the body. And we know that one of the common complications of COVID is organ dysfunction, whether it's, lung issues or, and people that need dialysis. And so in order for us to protect patients that already may have compromise to those organs, those important organs, the best thing to do is to prevent them from getting the disease altogether.
Thank you. Takesha, did you want to address that?
Oh, I was going to say exactly the same thing. So these are the people that we are targeted to get the vaccine first. Those are the people that have the highest risk of succumbing to the COVID virus. So, I mean, always talk to your primary doctors or your specialists, but these are definitely people that the COVID vaccine, is made for. Those are the ones that are succumbing to it the fastest.
Thank you. And Dr. Heyer, I'm assuming you agree.
I do. We did enroll a number of people with comorbidities into the study, and so we do have the safety data on those people, and of course we're continuing to monitor the study for safety, the participants in the study, as well as the broader population through the initiatives that are being done by CDC and FDA for safety. So,
thank you. Megan, you have another question for us?
Yeah, we had a question from Galena K, who wanted to know if you could give some general do's and don'ts for people who are going to get vaccinated.
I don't know why I just started speaking, but
go ahead. Please feel free. Feel free.
So I think I can only speak from my experience. I pretty much tolerated the first shot like nothing. I felt nothing. I got it. I'm like, oh, this is great. I will say, and what I've told other colleagues and, people, family members that have been able to get the vaccine is usually after the second vaccine, I would just plan it that if you're working, maybe take the next day off or plan for a work from home day, just so that you're prepared that if I know people, the colleagues that felt nothing after the second vaccine, I know people like myself who had to stay in bed. So just prepare yourself for that. I don't think that there's any don'ts that I would do, but be aware of, but I would try to just be off the day after the vaccine, the second one.
Thank you.
You know what, Luis? Yes. Oh, great. Thank you. So I would add, and I think I'm going to get Dr. Heyer for this, but you are not supposed to have another type of vaccine within a certain amount of time before you get the COVID vaccine. Dr. Heyer, I think you can maybe speak to the exact time frame. But.
Yeah. Of course, I have no direct data because we didn't have anybody like that in the study. But there are general guidance that the CDC publishes, which is roughly 14 days. And I would be very pay very close attention. To CDC guidance. They publish very good information about things like this. So, I think the most important do is wear your mask when you get vaccinated. Okay, and wash your hands and maintain your social distance, please. And then maybe just the general idea that we know that after the second dose, you may feel more of the symptoms. Maybe that's a good day to plan an easy day.
Mm-hmm.
Thank you. And we're going back to Megan.
We had another question from Ms. Scanlon, and she wanted to know, is it legitimate to characterize the lack of vaccine uptake within certain communities as vaccine hesitancy, when in fact there are historical harms within those communities and a continued lack of supply?
So I would just, sorry, Luis. I'm sorry, Luis. I'm going to wait for you to call on me. I apologize.
No, it's okay. It's okay. We'll just bump every once in a while. It's fine.
No problem. So what I would say is that, part of what I do at our practice is to educate and then try to make sure the vaccine is available when the person decides to get it. But we have to acknowledge the historical, trials and tribulations and mistrust in the medical system against Black and brown people. And I think that, we can't ignore it. We can't hush it. It happened. It's not like something is made up. But I think that the difference is that this affected, COVID did not, have color, creed, Black, white. I mean, it affected everyone. And so I think that if we look at this in this way, this is our best chance to get back to some sort of normalcy without discounting the fact that people are afraid for a reason, that they're not just making it up. So I think we have to acknowledge that. We have to speak to it. And then when they're ready, we have to make sure that the vaccine is available for them. I don't call it vaccine hesitancy. I call it, we need to be able to have more town halls, answer questions, be honest and transparent. And when people finally decide to get that vaccine, we need to make it available for them.
Thank you. Thank you. Did anyone else want to address that? Dr. Vila said no.
That was perfect.
Dr. Haya?
I was going to say, I thought that was very well said. And, we did, I just want to mention, we did go out of our way to enroll the study to represent the United States as close as we could. And we're very proud of that effort. And I hope that effort will give a degree of security and trust by communities that have been the Black and brown communities that we are watching very closely for safety and for the effectiveness in your populations. Thank you.
Thank you. We have 4 minutes left, so this is going to be a rapid fire question. Megan?
Thanks, Louise. So we received a lot of questions from people who are really eager to get vaccinated. Susan G wanted to know if anyone has an idea of when you can tell us when we can expect to see an increase in the supply of vaccines.
Okay, panelists, 1 minute or less. How about less? Dr. Davila, did you want to answer that?
I work in the hospital setting, so it's a little bit different for me. I think maybe Takesha could answer this. She works in the outpatient setting.
So what I would say is that, first of all, we're praying. We're all praying for these vaccines to come, guys. But the federal government just designated a lot of community centers and FQHC as hubs to be receiving vaccines. And what we're seeing is that we are advocating for our patients in our communities every day. And we are trying to get these vaccines out as quickly as we can. So I can't give you an exact date because I'm not on the federal, I don't know all the federal, stuff. But what I will say is that when these vaccines come, guys, we are informing people and we're getting them out in the communities that need them the most. So.
Thank you. Dr. Heyer, I guess you'll have the last word on this.
I say we're doing everything we can to get it, make it available, produce as much as we can, as fast as we can to help people. So that's what we're here for.
Thank you so much. So thank you for your time. I want to thank our panelists for the time they spent with us this evening and for the information they shared and for their enthusiastic way of answering the questions. I appreciate it. So I'm just going to let everyone know and thank everyone who participated, but I want to let you know that our next fireside chat will take place next week on Wednesday, February 24th, which is outside of our usual time. We usually do it on Thursday or Friday, but next week will be on Wednesday. That session will be specifically for our Spanish speaking community.
Awesome.
So please, if you know someone, especially someone who only speaks Spanish, please let them know. Please ask them to tune in and to register. And we're so grateful to all of you for sending your questions in ahead of time and for your participation in this, for your interest. We hope that the information that's been provided to you is helpful and it will be informative as you make your decision about getting vaccinated. So again, thank you all for participating. Thank you, Dr. Heyer. Thank you, Dr. Davila. And thank you, Ms. Takesha Leonard, family nurse practitioner. Thank you so much, all of you, for being here. Have a wonderful evening.
Thank you. Thank you, guys.
Thank
Bye-bye.
you. Bye.
Take care.